Hello, good evening. I hope you can hear me. As I'm trying to share my screen, as also I'm admitting those one who are joining this time, so that we can start. I think we are still around 13 now, but we are going to start. We are going to discuss clinical chemistry. Is all about exam structure and the exam questions, how we expect and what we can actually know about the exam questions and how we need to answer the exams. Okay, let me try to share this screen so that we can start. Okay, I think this one is okay. Okay, all right. I hope you can see. You can see what I'm sharing. I'm trying to share this screen. I hope you can see.
Yes, it is seen.
All right. Okay. Let me just try to get rid of this. I'm trying to admit. Those one who are coming late. Okay. Now, let's discuss about this chemistry or clinical chemistry exam, and we try to take our time and we discuss. So it's not a lecture. We are going to share our experience and see what ASCP is has to prepare for us when it comes to exam. Okay, so clinical chemistry, this is how it is. It is composed of four major areas. Yes, the same thing that we have also in our content. Because our trans class content, it is prepared according to ASCP content guideline, and in the four areas, the same as other subjects, not only for clinical chemistry but also others. You would see that we have what we call MLT questions and what we call MLS only questions. So those are the two kinds of questions are different. So because MLS questions, mostly these MLS only questions are those intended for medical lab scientists, but not medical lab technicians, because we have also medical laboratory technicians, those one who are doing MLT. It is known as medical lab technician, and those one only for those who have who hold advanced diploma, especially advanced diploma in MLS or MLT. Yes, but of course, mostly those who want to apply for MLS, those with a bachelor's degree, they will be able to do these questions that are written as MLS only. But this is only here. But when it is a real exam, of course, you cannot see such thing of MLS or MLT. So you just see a question wherever it is coming from. So you have to answer it. Okay, so now as you can see from our four sections, general chemistry, this is for clinical chemistry. We have general chemistry, we have also proteins and enzymes. You see, that is also another section. We have also acid base, and blood gas and electrolytes. So they are somehow related. That's why they are together, acid-base, blood gas, and electrolytes. Sometimes it is not possible to request for acid-base test without blood gas or without even electrolytes all together. They're usually requested together. Okay, so that's how it is. And the last one is about special chemistry. So for special chemistry, we have special tests, including, for example, we can say hormones. Okay, we can talk about therapeutic drug monitoring. You can talk about toxicology. So all those are included in special chemistry. So that is what we call special chemistry. So now, yes, what we are going to discuss here mostly, because questions are many, so we can't finish all to get today. What you are going to focus on today mostly are those significant questions, or the questions we have been encountering in multiple exams, like different exams. Sometimes people have been commenting or giving us feedback, maybe which questions they encountered in their own exams, and so on. So that's what we'll be talking about. Not everything, because we have more than 500 questions in chemistry, so we can't finish all of them. But God willing, when we get another time, maybe we'll come back and look at them. But it's just also to show you, or to try to highlight how you'll be trying to answer them when you are getting ready, when you're preparing for exam, when you are finished to read. You can actually go through the questions and try to answer them, and see how the questions are set and how you can answer them. So this one is just, yeah, some of them are just very simple. Some of them are just very simple. For example, like this question number 1. So we are not going to answer it, but we'll, okay, it is okay. Though this question is just very simple. Like, for example, when they say this is about carbohydrate, which is in general chemistry. Yes, we're not going to answer this one. We're not going to discuss more about it, but we have question number 2, question number 4, 5, 6, and so. So this one is not for MLS only, but it says the following: overnight fasting, hypoglycemia in non-diabetic adult is as glucose of, they say, less than or equal to 45, 55, 60, and 70. So if you remember in our notes, there's one thing where we say that for someone who is not hypoglycemia, there's what we have in our notes. Hypoglycemia, we have it in carbohydrates. Someone with around 50. In our notes, we talk about, we mentioned 50, because in most books you find 50, between 50 and 55. That's what you say someone is having hypoglycemia after overnight fasting. So the person without diabetes, we can say this person has a disease, because hypoglycemia is a condition, is abnormality. Okay, person has disease when the person has about 50 to 55 milligram per deciliter. So it is less than or equal to 55, but it is not 45. 45 is another thing, which is also there in the notes. So 60 is not possible and 70 is not possible, because 60 is not a condition of hypoglycemia. It's a low sugar, but is not a condition as hypoglycemia. It is 50 to 55. Okay, less than or equal to 55. So the question number 2. Because we are going to share, we are going to start from this question number 2. So the question number 2 says, the results shown in this table are from 20 1-year-old patient with a back injury who appear otherwise healthy. This person has back injury, but the person appear otherwise healthy. And what I want to actually to mention, what do they want you to know here? That's what I want to mention here, because the question is very straightforward and it's very simple. But what they want to hear for you to know. Who can answer this one? And then I will you can mute yourself and answer this question, and then I would try to tell you what really they want you to know when they display this particular question. You can see we have they are saying that whole blood glucose is 77, serum glucose is 88, okay, and glucose of CSF is 56 milligram per deciliter, okay. And they were asking, how do we interpret this result? They are saying the A is the whole blood and serum value are expected, but the CSF value is elevated. The whole blood glucose value should be higher than the serum value. All values are consistent with a normal healthy person, okay? And the serum and the whole blood values should be identical. Okay, who can answer this question? And let's see what actually they want you to know before answering this question. Okay, who can answer? Yes, we're trying to, and someone is writing in chat box that this question they are testing if you know the normal values of glucose in each body fluid. Yes, that is correct.
Hello?
Yes, Aaron.
Yes, if I remember well, even though I didn't attend for clinical chemistry, but for fluids, I have seen that the difference between serum and the CSF blood concentration should not be above 30 milligram per deciliter. So here, I can see that CSF is 50. The difference is above 30 milligram per deciliter. Thank you.
Mm-hmm. So what do you answer here? What do you choose as your best answer?
Let me check again.
Yes. So what is trying to explain is correct, and what do we need here to know is that the difference is not about only body fluids, but whole blood glucose and serum glucose. These are significant things, and then glucose in CSF. What you remember is that what you have to know is that between whole blood and serum glucose, there should be at least the difference between glucose and glucose in serum and blood, whole blood, there should be at least between 10 to 15% difference. 10 to 15% difference between the two. If the difference is maintained, the result is normal. Why? Because serum glucose should be higher than whole blood glucose. Because you remember when we are like testing glucose, we are testing glucose in serum. We are testing glucose in plasma, not in whole blood. I mean, not in RBC, in plasma as a fluid. Okay. When you are testing glucose in whole blood, that plasma contains RBCs, red blood cells. And if the plasma contains red blood cells, so it means that the red blood cell will actually replace water or liquid. So that's why that will affect glucose level in the whole blood, which will be will be decreased comparing to the glucose in serum. Serum glucose will be the real glucose we want. It is the real glucose we are testing for, because that is what we are actually looking for, plasma glucose or serum glucose. But whole blood glucose, of course, it also contains serum, but because of hematocrit, will also affect the glucose level. So you can see that the difference between whole blood and serum glucose is maintained between 10 to 15. But also remember, CSF glucose, I don't remember exactly what Elia said, but for CSF glucose, as you see it here, CSF glucose must be around 70% of serum glucose, around 70% of serum glucose. So, and you can see this is serum 88, CSF 656. So, which is approximately around 60 something, 70, around 70% of the serum glucose. So, which is all values are consistent with the normal healthy individuals. So, this is the C is the one correct. Okay. So the C is the only correct because all the values are consistent, like 788 is normal, 77 is normal, and even 56. Sometimes if someone doesn't know the normal range of CSF glucose, sometimes you can be confused because even though the two of them are normal, but sometimes CSF can be abnormal. But if you don't know the range, you can be confused here. But you should always remember it is around 70% of this serum glucose. That is the glucose for CSF. Okay, I hope that one is a bit clear. All right, no one is trying to get in. Now let's go to question number. And the third one, this one is very simple. It's a bit simple. The standard, the glucose tolerance testing. Let's go to question number 4. Question number 4 is saying, if fasting glucose is 90, which of these two postprandial glucose results would most closely represent normal glucose metabolism? If fasting glucose is 90, which 2 hours post, you remember what is called postprandial? Is glucose after eating, after meal, after food, okay? Like 2 hours after diet. Okay, what would be represent, and what happens for, like, what can you say that this person after 2 hours postprandial or after 2 hours after meal, what would be normal glucose metabolism? Of course, after testing, and you find what is normal glucose metabolism here on the question number 4. If the fasting glucose was 90, because you know what you do when you are like what you hear, what they also want to know, you to know is that you have to know the process of doing fasting glucose test. Okay, you know that a person has to fast for at least 10 hours, 8 hours, but not exceeding 16 hours. Okay, that is fasting time. And then when they come to your facility, what you do is to test for what? For the baseline, what you call baseline, initial glucose concentration. That's what you call baseline. And you give them 75 grams of glucose. Okay, then after 2 hours you test, and if the metabolism is good, so this is a glucose tolerance. But postprandial is also the same. You give them meal, okay, you give them food, and that glucose content after 2 hours you have to test for glucose concentration. So what would be the normal range here? I think also this question is very simple, isn't it? I think it's very simple because of the ranges. What is the normal range here? I don't think I will be able to be visiting chat box. It is difficult because
I think I want to try if it's okay.
Yes.
I think the answer is B, because the expectation after 2 hours is that the blood glucose is back to
Yeah.
the normal.
Yes, back to the normal. Yes, because that is very important. Like what we want to remember here is that after 2 hours, anything you do, whether it is food, whether it is like glucose tolerance that have given you sugar, it has to metabolize to the normal range, which should not exceed 126, isn't it? 126. That is postprandial 2 hours. That's what is normal. So when it is fasting, normal range for fasting is between 70 and 110. You remember that one. So for this, in this case, both, whether it is fasting, whether it is postprandial, 100 milligram per deciliter is very normal for this person. Okay, let's look at question number 5. So they're asking, let me try to do like this. Can you see it? Let me try to move this thing. Oh, sorry. Oh. I think I have distracted my.
It appears normal on the screen. I don't know what you're seeing that side, but to me the screen looks okay.
Oh, okay. So let me try to bring it back because for me I can't see it. I'm trying to bring it back. You know, Zoom has got so many features. I'm trying to see if I can bring it back on my side because on my end I can see. Okay, I can see the screen, but it was not normal the way I was seeing. And I want to do this. Okay. I think this was coming. Okay, all right. Okay, so let me try to let me actually the stop share and then I share again because I don't know what happens. Okay. Okay, I hope the screen is back, eh?
Yes, it's back.
All right. It is like, this kind of Zoom has got so many features, so it is sometimes it can be disturbing. Okay. Okay, so we are now on question number 5. Let me see if, okay, this one is fine. We are talking about a healthy person with a blood glucose of 80 milligram per deciliter who would have the same determined cerebrospinal fluid of, this one is very simple, isn't it? I think we talked about it, the ratio between CSF and blood, because they're talking about here blood glucose of 80, and they're asking what would be the simultaneous level of cerebrospinal fluid level glucose. That is going to be 50 because of 80 here. So you can't say 25 to be very abnormal, and you can't say 100 because 100 is above 80.
Excuse me. So for the question for postprandial, I think it is not 100. You can check because most of time the value is 180. You can check. It is not 100.
Which question?
Number 4.
Hey, are you sure? When you talk of normal, we are talking about normal glucose metabolism. Do you know what is going to be when after a meal? What is normal glucose metabolism? Do you think 180 is normal?
After meal,
It is
that
not
is
normal.
the normal value. You can check.
I think that's less than 2 hours, before 2 hours pass. But by the time 2 hours pass, in my opinion, it should be back to the normal 2 hours from
it
the
should be
time
normal.
last.
Always 2 hours must be normal. It must, not even, it must be normal.
The answer is B. The answer is B.
Yes, the answer is B because glucose can be 180. 180 is like actually like 30, maybe 30 minutes, maybe 1 hour, around that. But when it is 2 hours, for the normal metabolism, glucose should have returned back to normal, which is of course after meal. If you read, it is very important you go and read clinical chemistry, carbohydrate. We have that one. I think Mr. Frank is the one who taught this one. Yeah, but after 2 hours, for the normal glucose, it should be at this level of 100, 120, 110, and 100. That's normal value. But when it is 80, that is pre-diabetic. You can say pre-diabetic with symptoms. But when it is above, you remember when it is 200 and above, that's what we call diabetic. And when it is together with symptoms, symptoms plus 200, it is diabetes. But in this case now, you see it is very high as well. 108 is very high. So let's go back to our question 5. So, but this 5th question, we don't need to. Okay, it is just it is a repeated question from the previous one, because we explained that the level between glucose of blood and CSF, there must be at least around 70% of the blood glucose should be the level of normal CSF glucose. Okay. All right, let's go to question number 6. Where they just give us what 25-year-old men become nauseated. This is I think this question is very tricky. Okay, it is very tricky, but we are going to see how to deal with it. 25-odd. If they start talking about age, then it is a case study. Age: 25-odd men became nauseated and vomited to 90 minutes after receiving standard 75 carbohydrate dose for an oral glucose tolerance test. This is OGTT. So the best course of action is to do what? So this person has vomited. This person, the first thing is that the person nauseated. No? First of all, it was nausea and then vomiting. 90 minutes. 90 minutes is how many hours? Is like
1.5 hours.
Yes, like 1.5, like 1.5 hour after receiving 75 glucose. This is like a tricky question. They want to ask you what happens. What do you do? What did you do when this person give the patient a glass of orange juice and continue the test? And then start the test over immediately with 50 grams. Draw blood for glucose and discontinue testing, and place the patient in recumbent position, reassure him, and continue the test. What test I got to continue? So what can we answer here? What can we answer here?
C.
C. Why do we answer I see? Is it to draw blood and discontinue, draw blood for glucose and discontinue test?
By using the elimination method,
We are using the elimination method.
Okay, that's what I used to give the answer.
Yeah, it's a
We
good
can't
thing.
give the patient juice because that is going to
Compromise
interrupt
everything.
the test.
Yeah, it's going to compromise everything.
Yeah. And then I'm waiting for something to get off the screen. We can't start the test over by giving 50 because that's already going to be more than the 75. The calculation won't come out well. And then placing the patient in a convenient position. It's not like our patient fainted and you're trying to bring them back to life. No, they're okay. Yeah.
Yes.
So I remember.
Remaining the C. Yeah, it is actually it's a strategy that I forgot.
I have a different opinion.
Let me first of all thank Olive for reminding me something. Because I forgot to even start with the telling you which strategies I usually advise my exam takers when they are going for exam. Sometimes when something is challenging you, what you do is just to eliminate what is unlikely. So just eliminate, remove it, because in exam we also have four options like this. We don't usually have more than 4 or less than 4 options. When you remove 2 of them, you are increasing chance, because if you are able to remove 2 of them, now you are now dealing with 2, which means you have 50%, even if you just choose blindly from them. So you have 50% of getting it right. So elimination method is very important, but also we can maybe add some explanation from this C option because it is the correct one. Yes, Pascal, do you want to say something before I?
Yes, I was also choosing C. But I wanted just to add an explanation why we draw the blood for glucose and we discontinue the test. Because we expect normal metabolism actually to have occurred within those 1 hour and 30 minutes. Because normal metabolism always occurs between that time to 2 hours. So we expect actually the body to have assimilated the glucose already of this test. So why we draw the test, why we draw the blood for glucose is because actually we are sure that our test at least within that 1.5 hours, we will get a certain value which would be like, how can I call it, like sort of a preliminary value.
Yeah, that is correct. In fact, what you now, yes, it is not that it's not 100%, because even vomiters, sometimes when someone vomits, they also vomit glucose. Maybe some glucose, some amount of sugar is also vomited. So yes, but at least maybe you can say more than 80% of the sugar has been metabolized. So when we draw blood, at least we can have, that is what you can call preliminary result, or at least useful information about patient health. Maybe you can repeat a test next time, but at least that can give you, it is not accurate, but at least a useful information can be given by this patient. So this one is also simple. So this kind of carbohydrate analysis. So let's go to question.
Excuse me, sir. I was wondering. I wanted to inquire, sir, what would happen if we just reassured the patient and continued the test?
If we do what? Which option is it?
If we went for D, option D says we reassure the patient and continue the test. What would happen if we continued the test anyway?
You're talking about B. The B.
D. Option D. The last option.
Oh.
If we reassure the patient and continue the test, what would happen?
No, that one will affect. That one will affect, in fact. Okay, we can ignore placing the patient in a coming position. But yes, we can, whether we ignore it or not, because this position is not for someone who's vomiting. but reassuring the patient and continue the test, it will be worse, because at least we can confirm that whichever result we obtained here, the result of 1 hour and 30 minutes, so which is around 2 hours, like what Pascal said, which around 2 hours, and we expect that almost even 90% of everything has been completed. But if we reassure the patient and continue the test, we are going to get like abnormal result after that, because the metabolism being happening, or the metabolism of glucose, the glucose that is in blood is not the exact amount of glucose we expected to be in blood. So that glucose will also be metabolized quickly, and sometimes you may get maybe a worse result. I don't say that drawing blood and test will get a correct result for glucose, like what you wanted, but at least when you test directly, you know that the glucose that I'm testing is what is being metabolized at 1.5 hours. But if I continue, I don't know now what is going to be metabolized, because already some of it was vomited by the patient. So that's why this one could be the best. Yes, sometimes options can be similar. Sometimes one option can be good, but of course we have to look for better one. Yeah, so I have to look for a better one. So in fact, sometimes you find that two options can be somehow, one of them can be somehow okay, but at least look for the best one. So for the question 11, we have this one, pregnant women with the symptoms of thirsty. This is about pregnant women, and you know what we do for them is what? It is even here. Some is having thirsty, which is a symptom of hyperglycemia. Frequent urination, it is also a symptom of hyperglycemia. And unexplained weight loss, this is a symptom of diabetes. And which test can be performed? This person is a pregnant woman. These people are pregnant women, and they are showing all these symptoms of hyperglycemia and symptoms of diabetes, which is unexplained weight loss. What test do we perform here?
I think glucose tolerance test.
Yes, glucose tolerance test. So because, like, for example, lactose intolerance is performed for someone, for example, who is who has a problem of indigestion. That's what we call lactose intolerance test. Epinephrine is also not necessary for this mother. Is that because we're trying to get rid of this test, this other unrelated test? But don't waste your time, because what you see here is about diabetes. The patient is having diabetes symptoms. So, and you know, for the mothers, you remember, for the mothers, we don't do fasting. Never. We don't do fasting for them. We don't do we don't do random. We don't do postprandial, but we do what you call OGTT. OGTT is done for pregnant women. Always, when you are going to screen for them for the diabetes, we do OGTT. And you remember what you have in our notes, that we do two-step method. Two-step method. The first step method is to give 50 grams, and then if it is abnormal, we give, and again, 100 grams. So you remember the way we do it. We have it in notes. It is what we call two-step method for the mothers. Two-step method is not done for any other person, but is done only for pregnant women. Two-step method. Just remember that one, and how we do it. To give 50 grams, and then after 1 hour, we test, and then we give another. When it is more than 144, if I remember well, then we give another 100 grams, and we follow 3 hours. Okay, so it is D. And let's go down to which question? Question number 16. Oh. Question number 16. Question number 16. Yeah, I was trying to choose some like good questions that can be helpful to us, because otherwise not every question is good here. It is just wasting our time sometimes, because some of them some are easy. They don't require much explanations. Patient with type 1 diabetes, insulin dependent, is showing fasting blood glucose of 150 and HB1C is 80.5 and fructosamine is 2.9. I mean, the normal range is this one, and the level is 2.5 millimole per liter. So this one is fructosamine. I hope you remember that we also have it in our notes, fructosamine and the use of it. HB1C, we also have it, and fasting blood glucose, we have it as a test. So after reviewing this result, what could you do as a technologist? What could you conclude with that patient? The patient, is he in a steady state of metabolic control? Is the patient in state of flux or progressively worsening metabolic control, or the person is improving state of metabolic control because of the fructosamine, and the steady state of flux as indicated by the fasting blood glucose level? Yes.
I think I would go with C.
Yes, Daniel. This person is having a C something, improved state of metabolic control as indicated by fructosamine. Yes. So, yes. Previously, we didn't have this particular fructosamine in our notes. But after this question, we reviewed our content and we added the significance or the use of fructosamine. Yeah, for you guys who maybe joined like in one year, you have seen this one in our notes, but maybe 2 years ago it was not there. So we just reviewed. We usually read questions like this and we review content sometimes because they would add something new, and of course we have always to be monitoring questions, and we include. So fructosamine is fructosamine is just like glucose will bind to the albumin. Then they will form what is called fructosamine. Albumin and glucose, the same way it binds to hemoglobin, HB1C. You know? Oh, these people. Someone is trying to call me. Let me try to put it in silent mode. Okay, yes. So HB1C, of course, it indicates that someone has diabetes. Confirmatory test. HB1C 8.5 is very high. It can confirm diabetes. Fasting blood glucose is also high. You can see our normal range, as we said, it is 70 to 110. So when it is this level of 150, it is very high for this patient, diabetes. So fructosamine is actually normal, because what is happening is that there is at least a metabolic control, which means because the way fructosamine binds, or the way fructosamine is generated after binding of glucose to the albumin, so it depends on the concentration of glucose in the blood. So when glucose is increasing excessively, fructosamine will also increase, because it will reflect like 2 weeks glucose content in the body. 2 weeks, not 3 months like HB1C, but 2 weeks. So when 2 weeks is normal, then you can say at least there is a somehow improving state of metabolic control. But you can't say it is steady state because of these changes that you can see also HB1C, it is not actually normal here, and it is not improved for some time, because it reflects 2 months, 3 months glucose levels. When it is a high like this, There's nothing like steady state of metabolic control, but at least metabolic control is.
Sorry, sir. Please. So the answer is A.
Sorry?
Sorry, please. Is the answer A? Steady state of
No.
metabolic control.
No, it is not A, it is C. How? It is not steady state. It's not steady state of metabolic control, because some results here are still abnormal. Yes, but the state, it is improving state. Improving because why? Why do we say it is not steady but improving? It is because fructosamine reflects glucose level 2 weeks for 2 weeks time. So which means there is something improving in the 2 weeks, but not more than 2 weeks, because HbA1c is still high. Because HbA1c can show the improvement over 3 months. So if it is more than if it is only 2 weeks, but not more than maybe 2 months or 3 months, you will see that HbA1c is still high, but fructosamine at least is showing improvement. So it is actually improving state, but not a steady state for some time, as indicated by HbA1c. I hope that one is, they're trying to make it a bit clear, but because HbA1c is still high, fructosamine is in control, which means the state is improving, but not for a long time, not over 3 months or more than that. So, but at least because this one indicates the 2 weeks improvement. Okay, so now let's jump to the question number. This one I think was also a bit complicating. Yes, this one is what I also chose because it was a bit demanding. So we have question number 19, where they're asking about hemolytic anemia with glucose level. What the relationship between hemolytic anemia and blood sugar? So a patient with hemolytic anemia will show a decrease in glycated hemoglobin value, or increase this value, or little or no change about this value, or demonstrate elevated HbA only, HbA1. What if someone is having hemolytic anemia? What is happening?
There's excessive breakdown of red blood cells to release hemoglobin.
So it will be increased.
No, what happens in hemolytic anemia is that there is excessive breakdown of red blood cells to release hemoglobin. That means in that state, hemoglobin, I think it will decrease, not so?
Not sure, but you are right. It will decrease, because what we need to remember also here is the mechanism. Is method of testing HbA1c. What the method we use? We use a method of breaking down RBC first, because what we are doing, when we are testing for HbA1c, we have to use RBCs, not plasma, not serum. We use RBC, and we break down RBC, release hemoglobin A1c, and then measure the concentration or the binding of glucose to that hemoglobin. So, and we report it in percentage, isn't it? Percentage of all hemoglobins, the hemoglobins in the body, in RBCs. So when there is a problem of hemolytic anemia, because RBC red blood cells are decreasing, that will also negatively affect glycated hemoglobin levels. It will also be decreased. That is why we say it is decreased, because there is ongoing breakdown of RBCs, which is causing the reduction or decrease of RBCs in blood, and of course affecting the red blood cells that contain this HbA1c that binds glucose. So that's why it shows a decrease in this hemoglobin value. Okay. Yes, we just wanted to see the relationship because you may also see this one in hematology sometime when it comes to hemolytic anemia. Yes, please.
Could we also say that when hemolytic anemia happens, there is also like the body tries to respond by producing more RBCs that are young, and yet we know that HbA1c is, I think, mainly the old RBCs. That's why it measures up to like 3 months. Could that also be part of the explanation? So we are reducing the old RBCs because there is hemolysis, and now there is increased number of young RBCs that may not be having the glycated hemoglobin.
Yeah, yes, that can be in fact a part of it. Yes, so what you can say is that when RBC is produced, when it is mature to be released into bloodstream, when someone has hyperglycemia, even hemoglobin will diffuse quickly into red blood cells and bind. Even young ones, not young, I can't say young, but maybe newly released, newly mature ones, younger, okay, let's say younger ones in the blood, okay, they will still contain some amount of those ones that contain HbA1c, because HbA1c is a part of hemoglobin, is like a fraction of hemoglobin, because we have also others, HbA1, HbA1a, HbA1b, and HbA1c. We have those, all of them, like here, like this question here, because it is a simple one, but we skipped it, but it shows the fractions of all hemoglobins, HbA1, because we have HbA1 and HbA2, hemoglobin A2, hemoglobin A1. So hemoglobin A1 has got also fractions, hemoglobin AA, hemoglobin AB, hemoglobin AC. So any RBC that contains hemoglobin AC will be affected, will also bind some glucose. It can be somehow, it can somehow influence it, can influence the decrease, but the fact that, your concern is very true, because newly produced RBCs will not contain the same amount of glycated hemoglobin as the old ones. So when we test all of them together, and that can decrease the overall percentage of HbA1c. Yes, thank you for your contribution. So it is very clear, and when you think about it logically, you will understand why that can contribute as well. Okay, now let's go to this question. Yes, this question has been coming multiple times, and I think some people told me this question was coming in the exam. This one, question number 22. This one. Infants with diarrhea is being evaluated for carbohydrate intolerance. His stool produces a positive kappa reduction test and pH of 5. Okay. It should be concluded that this young infant, further tests required, results are inconsistent and repeat both tests, and diarrhea is not due to carbohydrate intolerance, and the test provided is not useful information. Provided no useful information. What do you think about this particular thing? Like this small boy or small girl, I don't know, has a problem of stool which is showing copper reduction test positive.
Okay, let me give my opinion.
Uh,
I think
mhm.
on that very question, first of all, if we look at the question itself, the boy we are testing him for carbohydrate intolerance, but his stool is giving a positive test on copper reduction, which means the stool is actually having some reducing sugars, because copper reduction is for reducing sugars like glucose, so which means they are appearing in the stool of the boy. But the pH is also 5, which is correct. So I would go with the C, which is the diarrhea is not due to carbohydrate intolerance. Because if it was due to carbohydrate intolerance, we wouldn't see that breakdown leading to the monomers like glucose, which would appear in the stool.
Now, you're talking about, you are saying the C
I
is
also have
correct.
an opinion.
Yes, please. Yes, who is that? Oliver? I think Oliver. Huh?
Yeah.
Yes. Mhm.
Yes, the copper
Yes,
test is positive, but usually I think I remember copper being usually reacts at a pH that is alkaline, and that pH here is acidic. So that's why I would eliminate that C and maybe think of a BOA.
BOA.
Yeah.
Yes, Oliver, do you see what you are talking about is correct, but what we know is that, yes, pH of 5, the pH of 5 is of course acidic pH, yes, which is correct. And when you are testing the copper reduction test, it is called ferring test. Ferring test, when we are testing, we add sodium hydroxide to achieve alkaline pH. Yes. So pH of 5 was stool pH, not test pH. Isn't it? Is this a
Could I
pH of
also
stool?
give it a try?
Oh,
Yes,
if that's the case, then our answer is going to be A.
A, okay.
Yeah,
Because if
sure.
both are
Even me, I
correct,
would go with A.
Yes, thank you, Daniel and Oliver. So yes, because when we are doing, you remember how we do ferring test. Everything is there. There's no way you can do ferring test at a pH of acidic, because everything in a ferring test, for example, if it is one we choose to do, everything is there, and sodium hydroxide is there to make it alkaline. So this is just pH of stool. So Pascal talked about this one, and he mentioned that we should answer the diarrhea is not due to the carbohydrate intolerance. Is it true? No, this is, what is carbohydrate intolerance? It is what we call indigestion. When someone is having indigestion, this person will not be digesting carbohydrates. So when the person is having indigestion, and the person can lose carbohydrates in way of diarrhea. So you remember in body fluids, I know you are doing body fluid now, but allow me to bring it here in chemistry. Body fluid, when you are doing stool fluid, no, is it not? Fecal fluid, it's called fecal fluid. Fecal fluid analysis. When feces contains carbohydrates, it means indigestion, and indigestion cause diarrhea. One of the causes of diarrhea is indigestion or an absorption or malabsorption. Okay, you can call it malabsorption and maldigestion. Okay, both of them. Maldigestion is one of the causes of diarrhea, and diarrhea, because of maldigestion, the carbohydrate is not digested. That's why positive copper reduction is positive. I mean, copper reduction test is positive. That's why, and this is the result we are seeing here are very abnormal. That's why further tests are indicated, have to be performed. Further tests must be performed, because we cannot say that diarrhea is not due to carbohydrate intolerance. It's not possible, because diarrhea is always due to carbohydrate intolerance. It's not always, but is one of the causes of diarrhea, carbohydrate intolerance. And what you see here is that because of carbohydrate intolerance, the stool of that infant, there is positive copper reduction test, which means reducing sugars are there and they are not digested and they are not absorbed as usual. And that can be a cause. Okay, I hope that one is a bit clear. Why we have to do further test, isn't it? We have to do further test. And because of when someone is having these problems of indigestion, the person will tend to produce acids, especially weak acids in stool. You read it in fecal fluid analysis. You see it there. Why pH is very low as 5. And that is it. I hope that one is clear, isn't it? Why we have to do further tests, because the results show there is a problem. Okay. Now, let's go to question 25. Then yes, 25 is good for MLS because we didn't have many MLS questions in carbohydrates, but you will see them in other areas. So for carbohydrate, let's finish with this one. It will be enough. The different water content of erythrocytes and plasma makes true glucose concentration in whole blood as a function of what? I think this one we also discussed it before. The difference water content of erythrocytes and plasma makes true glucose concentrations in whole blood as a function of what? Yes, so this one, let me try to answer for you, and then we just proceed with the enzymes and many others. This is because of hematocrit. As you remember what we said, we mentioned that glucose is measured in a liquid sample, in liquid plasma, but not in RBCs. So in fact, comparing to RBC concentrate, which is hematocrit, liquid part of blood is higher than hematocrit. So when there's only a small amount of RBC in whole blood will contribute to the reduced levels of glucose in whole blood comparing to the levels in, excuse me, let me admit these people, comparing to the levels in serum, for example. When you are testing serum, the levels is normal, but when you are testing whole blood, we would see around 10% reduction of the concentration of glucose because of hematocrit. When hematocrit decreases, that's why we are saying in function of what hematocrit, because when hematocrit decreases, it would increase concentration of glucose in whole blood. If hematocrit is very high, for example, if someone has maybe 60% of hematocrit, you will find that all blood glucose will be very low comparing to the plasma glucose of that person. That is why that's how I can try to explain why this question is answered like this, because hematocrit will influence the result of glucose because of the occupation of RBCs in whole blood, which will of course replace the water content of that sample. Okay. All right. I hope nobody is in a waiting room. This person is in a waiting room. Oh, person trying to join. Okay. Doris is trying to join. No problem. We have already admitted. Okay, let's go. I hope biochemists, carbohydrates, you can be fine. You are fine with the carbohydrates, and of course, you need to also try to read. Okay. Okay. So I hope you can hear me. Are you hearing me? Because I'm not able to see even my signals coming up.
Yes.
Oh, you're hearing me?
Yes, we can hear you.
Oh, okay. That's good. I was not able to see the signals of my microphone. Don't know what was happening. At least, okay. I hope it is fine now. You can hear me. Okay, let's go to enzymes. Now I think the another side is enzymes. Enzyme is starting from where? Starting from here. Okay. Yes. Okay. Now it is about enzymes. Okay. One international unit of enzyme activity is the amount of enzyme that will, under specified conditions of a substrate concentration, pH, and temperature, cause utilization of substrate at a rate of 1 mole per minute, 1 millimole per minute, 1 micromole per minute, and 1 nanomole per minute. So how this question wants to discover, if you remember, how the substrate is converted into products, and what is the amount of substrate that is converted to the products at a certain temperature, pH, and substrate concentration. Enzyme is there to convert substrate, okay, and substrate must be in a certain concentration in order for enzymes to convert it into products. And which concentration per minute? Which concentration per minute do we confirm here? Now, 1 millimole per minute, this is 1 mole, 1 millimole, 1 micromole, and 1 nanomole. What is the rate of substrate conversion by enzyme per 1 minute? What do you think? This one looks strange.
I think it's B.
B, millimole per minute. Millimole is a very big amount. Oh, let me help you with this one. It is micromole. It is a very small amount, like what what enzyme can convert at a normal pH concentration and temperature. It is in micromole always. And usually, if you read very well, you would see that enzyme convert amount of 1 micromole per minute, per 1 minute, just 1 minute. It is able to convert when a concentration of substrate is adequate. You know what we call the zero order of kinetics. So when the concentration of substrate is adequate and enzyme is adequate, then enzyme can be able to convert 1 micromole per minute, 1 micromole concentration of substrate per minute into products. Yes, that is how it works. All right. Let's see if there's any MLS only question here. This one? Yes, this one. Yeah, this one is also about MLS. In spectrophotometric determination, which of the following is the formula of calculating the absorbance of a solution? Yes, this is straightforward, I think. Remember spectrophotometer. How do we calculate the absorbance? How do we calculate absorbance? Absorptivity times light path over concentration. Absorptivity times concentration over light path. absorptivity times light path times concentration, and so on. What is what is it? What is the absorbance? Absorbance calculation is spectrophotometer. What is the absorbance? How do you calculate absorbance in spectrophotometer?
C?
Yes, it is C. You remember everything is times. It's times. Is it? There's no something as a maybe division or addition, because when we are trying to determine absorbance in a spectrophotometer, okay, what you are trying to discover is absorptivity of the sample. Absorptivity is like how good the sample can absorb light. Okay, then light path is a distance. Of course, it also depends on the thickness of the cuvette and everything. And then we look at concentration of the sample, because sample can be concentrated but has low absorptivity, maybe depending on what you are testing for, depending on the analyte we are trying to measure. So it means everything is times. Remember, absorbance calculation, everything is multiplication, there's no division. It is light, absorbance, and concentration times. Okay, thank you. Now we have also another MLS question is, this one is very simple, but let's go to question number, yes, 31st question. We are trying to know an example of glucose-specific colorimetric method. Glucose-specific colorimetric method. Which one is a glucose-specific colorimetric method? This one is also tricky. The question is very tricky. I hope you have discovered how tricky it is. I've discovered myself how this question is very tricky, because they are giving us all the techniques, yes, we use for glucose measurement. Alkaline ferricyanide, glucose oxidase, hexokinase, and all toluidine test. Which one is glucose specific? Glucose specific. That's specific.
I think it's B.
How is it B? Okay, let me help. Yes, you are right. Glucose specific is oxidase. Why? Because another test that is used for glucose is called hexokinase. You remember also hexokinase is a test that we use in most laboratory, in many laboratories. We use hexokinase. You remember hexokinase is what? Is a phosphorylation, isn't it? Phosphorylation of glucose to become glucose 6-phosphate, and then glucose 6-phosphate will be oxidized or dehydrogenated by glucose 6-phosphate dehydrogenase in order to generate what we call NADPH. Okay, you remember that one? Very straightforward. And then NADPH is measured as a color disappearance and the appearance. You know, that one is like that for hexokinase. But for oxidase, glucose oxidase, what happens is that glucose is oxidized and then glucose, when it is oxidized, it will now generate what we call gluconic acid, isn't it? And then gluconic acid plus hydrogen peroxide. And there will be the second enzymatic method, which is normally what you call coupled enzyme reaction, where peroxidase will also be involved in order to help peroxide converting a chromogen, and a color is generated, which is measured by a colorimeter or spectrophotometer. So that's how it works. Now, why is it this other ferricyanide is not specific? Ferricyanide can be used also for other tests, for other reducing sugars, even toluidine blue. Sorry, even all toluidine. It can also be used for other tests. Other sugars, for example, like mannose. Okay, so some of the sugars like that, some of them can also be used. Can also be tested by toluidine. So, but the two tests are really specific for glucose oxidase and hexokinase. You know that one. So, but why hexokinase is not specific? Who can try to explain to us why hexokinase is not specific? And we have described it. I have already described how it works. Why is it not specific, but oxidase is specific? Why hexokinase is not specific comparing to glucose oxidase? Who can try to think and tell us why? I'm waiting for maybe. Who am I going to ask? Maybe let me choose someone I can ask this question. Let me see in our participant list. Because we are many. Who is the person? Think about this. The two. I want you to discover something behind. Maybe let's ask Flemings, or yes. Flemings. Or even Oliver. This what did you discover about the two?
I could be wrong, but I'm thinking it's about the product. Since we are using the calorimetric method, the glucose oxidase product is a curd product, so it can be measured calorimetrically, but not the hexokinase. I don't know.
Okay. It is. Do you know what is hexo? Hexo is just hexose. It deals with hexose sugars. Hexose sugars is fructose, okay, galactose, glucose, all of them are hexose. So that's why it is not specific for glucose.
Okay.
That's what distinguishes hexokinase from glucose oxidase. Because even if you expose hexokinase, even if you expose like fructose or galactose, all of them will be oxidized. All of them will be phosphorylated because hexokinase does not oxidize, but it phosphorylates. Then the product will be oxidized. So Glucose-specific method is glucose oxidase, but not hexokinase, because hexokinase also can be specific. No, can also be applicable for other hexose sugars, other reducing sugars like fructose and so on. Yes. Okay. Then we have question number even 32 is a.
Excuse me, Monica.
Mm-hmm.
In that, I mean, on that particular question, it's when we look at the pathway of, I mean, of the reaction of glucose oxidase, the breakdown of glucose in presence of oxygen, right? I mean, in presence of water, and so to release gluconic acid and hydrogen peroxide.
Yes.
Yes. And then the product which is formed is colored, right? And a chromogen.
No, it is not colored. The product which is formed, is gluconic acid.
With.
Yes, it
Yes,
then
gluconic acid.
That peroxide will convert a chromogen, which is colorless, to a colored compound. Yes. Yes, please.
I thought a chromogen is the colored compound.
No. Chromogen is something that gives a color after a certain reaction.
Okay.
Yeah. For example, we may add something. We may add, for example, something that is not colored, like a colorless substance, because we want to test if hydrogen peroxide is there. When hydrogen peroxide is there, it will convert that colorless substance, which is called the chromogen, to produce a colored compound. That colorless will be converted into a colored compound. That's why it is called the chromogen. Gen, because it is going to produce a color.
Meanwhile, in the exokinase pathway, it relies on UV light absorption of NAD, right? NAD pH.
Yes, but also yes, yeah, but also for hexokinase, it is a very straightforward technique, because for it you just have to get an NADP, which is not
colored.
Yes, which is not colored, and it will produce the NADPH, which is colored, and this is going to be used. Mostly hexokinase uses spectrophotometer, not colorimeter, because what is going to do is the disappearance of the color because of NADPH.
Because what I'm trying to understand, in the exokinase pathway, there is no formation of a colored product, and yet in colorimetric measurement, we need color to be formed so that it can be measured. I think that is why glucose oxidase is a colorimetric, because this word colorimetric actually comes from color, measurement of color.
Yeah.
Glucose oxidase is colorimetric method. It is highly specific for colorimetric method because it leads to formation of a colored
color.
Yes. Unlike in the exokinase, it leads to the formation of the NAD pH, which has to be which is the one which is measured, and it is not colored. So that is why we use spectrophotometry.
Yes. Yes, it is, but also remember that NADPH is a colored compound. NADPH is also a colored compound because it is like the appearance of that color. NADPH is what spectrophotometer measures as absorbance, in form of absorbance. Yes, but also your concern is correct that here we just get a color, and what we're measuring is a color, and the intensity of a color by colorimeter is going to be proportional to the concentration of glucose in terms of hydrogen peroxide, because hydrogen peroxide function is what produces the color. Yes, something like that. Glucose oxidase also, it is more specific for calorimetry, because what you are relying on now, what you are testing mostly is the presence of color from the conversion of a chromogen by hydrogen peroxide, unlike hexokinase, because for it is just reduction process, which will also produce a colored compound, because NADPH is also a colored compound, which is, yes, it is also a colored compound.
Okay. Yes, it is colored compound, but it falls within the ultraviolet, which may not be
UV.
Yes.
Okay,
So
thank you.
Okay.
It is like that for sure. It's like that. Yeah, that is because it is UV light, which is measured spectrophotometrically. Okay, very good. You know, yes, it's like the way I like this session is that it's like we are trying to bring ourselves to how we can be using this book. It's not that you're going to answer every question, but at least now you can see how this book is very useful. This book of questions. Yes, it's just like for you, you answer, but you also think about the rest. Don't just answer and say it is A, because everything can be A or B, or say it is glucose oxidase, but sometimes can be challenged. So that's why it is very important to think about other options. That's why I really like this session, because we are trying to use it efficiently, because we are analyzing every question globally, including even many other non-related options that we have on board. Okay, so now we have also question 32, which is another MLS only question, which talks about increased concentrations of ascorbic acid inhibit chromogen production in which of the following commonly used glucose method? Oh, this one it is in our notes. I know even the line. If you are reading chemistry, I remember even the paragraph where this one is written exactly like this. Maybe if you covered it. Okay. For our new participants who did not cover chemistry, don't worry, we're going to have chemistry very soon. After methodology and blood banking, you'll have chemistry. But for those who covered our chemistry, you can see, you remember where this ascorbic acid is written in our notes, which method of glucose that ascorbic acid inhibit a chromogen?
What I remember it's in glucose oxide, one of the interfering substances we have acid. So I would literally choose glucose oxide.
Yeah, because even here, because we have already answered this question before. Because like, as you can see, we have been talking about the chromogen where? We have been talking about chromogen in oxidase. That's where we'll be talking about a chromogen, because we are saying inhibit a chromogen production. So it is epiloxidase. You know, what happens here? I remember what happens in this mechanism. Ascorbic acid will react with the chromogen, and it will inhibit the conversion of this chromogen into a colored compound. So that's what will happen with ascorbic acid. It will bind chromogen when it is high in blood. So it will reduce the ability of color production, because it binds these chromogens before hydrogen peroxide works on it, on a chromogen. So that is why ascorbic acid is a very, very, very bad inhibitor or interference in glucose oxidase method.
So literally, we can say that ascorbic acid competes, and it reduces. It reduces.
Reducer.
It reduces activity of peroxide, hydrogen peroxide, and the peroxidase, of course. All right. So let's see which one is MLS. Also, the next one is MLS only. Also, let's just look at it. Then we finish about these. I think this is also this is also these enzymes, about enzymes, but also enzymes for carbohydrate. In the hexokinase methods of glucose determination, the actual report and actual end products measured is the
Is B, not L.
Yes, NADPH. In fact, we call it NADPH or NADH.
Yes.
Yes, yeah, NADPH or NADH. But in most books we don't use NADH, but phosphate is there, not NADH. Nicotinamide adenine dinucleotide phosphate reduced. That's what we call it. So it is NADH, which is produced from the reduction of NAD plus, which is oxidized and reduced into NADH, which is produced by from this particular mechanism of hexokinase method. You remember we also mentioned it. I think everything was mentioned before. So let's jump to lipids and see what you can say about lipids. Okay, the first question in lipids is this one. High levels of which lipoprotein class are associated with decreased risk of accelerated atherosclerosis? High levels of which lipoprotein class is associated with the decreased risk of... I think this question is very simple.
Oh dear.
Yeah. D.
This question, yes, this question is quite simple. It's a D. Because what is the decreased risk of accelerated atherosclerosis? That is, having high density lipoprotein can be a very good factor for decreased risk of this condition.
Yep.
Okay. Yeah. Okay. So let's see. The MLS things are many here, but let's maybe pick one. Maybe Federal question. This is one is simple. You know, Federal question is a triglyceride, total cholesterol, and whatever. But let's see question number. Yes, question number 39. Number 39, which says the chemical composition of high density lipoprotein corresponds to. Yes, here they want you to know and to remember what are the composition of each lipoprotein in terms of triglycerides, in terms of cholesterols, and in terms of protein content. You remember talking about density of a protein, of a lipoprotein, you know, because we are actually classifying the lipoprotein according to their density. Some of them are known as low density, others high density, others very low density, or even intermediate density. We have them. So now, what about high density? What do we know about it when it comes to triglyceride content, cholesterol content, and protein content? HDL.
C.
Is B.
C.
C. Someone else? Okay. Well, okay, let me answer this person first. Yeah, we are dealing with the MLS question only. What about the rest? Yes, in most cases, MLS questions are the most difficult questions here. The other questions are simple. Yes, you can also, because for the carbohydrate, we dealt with the different other questions, not only MLS questions. But here, most of challenging questions, all of you guys may find difficult or challenging or even difficult to explain, because it's not about answering the question. It's about explaining to yourself, why do I choose this but not this? This is what we want you to be doing when you are reading these books. So we're choosing MLS questions only because those questions are the most difficult questions. Otherwise, those are the rest of the questions. Doesn't mean that you will not have them also in your exam. You may have some of them, but most of them are not really challenging questions. So yes, and you're trying to just bring this out, but next time we will also be including them others. Okay, that one is well acceptable. We'll be bringing also some others that are not MLS in the list, because these sessions will continue. It's not only for today. We'll try to be finding some time and we'll discuss some questions here. Just to help you trying to plan and to plan and structure how you'll be reading and how you'll be answering these questions. So what you answered as C is correct, because triglycerides, it is very low, because when a lipoprotein is a high density, it means that high density lipoprotein, it is very heavy. That's why you call it density. It is very heavy protein. It is a very heavy lipoprotein. And when it is very heavy lipoprotein, it means it contains the very high concentration of protein, because protein is heavy. So, but of course, triglyceride must be very low and cholesterol must be very low, depending, because it depends on where it is found. Sometimes it can correct cholesterol and bring back to the liver when it is doing what we call reverse transport of the cholesterol, but mostly it is around 15% of it. But the highest concentration of protein among other lipoproteins. So that's why it is known as high density lipoproteins. And remember, it is also the smallest among others, the smallest, because of the triglyceride content is very low, which makes it very small. Okay, that's why it is like this: 39 triglycerides, cholesterol, and protein, 5, 15, and 50 respectively. Okay.
Yeah.
All right. So now we go to this disorder. This disorder called familial hypercholesterolemia. We have it also in our notes, and even the 39th we also have it. Most of them, actually. This fourth question, it is asking about familial hypercholesterolemia. We call it FA. FAH.
Hypercholesterolemia.
Yes, familial hypercholesterolemia. It is. I think I was when I was teaching this course, chemistry. When I taught this, I explained that we have it as hypercholesterolemia, but doesn't mean it is a cholesterol problem. Don't confuse it with the cholesterol. It's because what is high is a cholesterol carrier, which is what I'm going to answer here. Which one?
Which is LDL, low density lipoprotein.
Yes, which is LDL, because LDL is a carrier of cholesterol, and when LDL is high, also cholesterol is very high, because LDL is the one that transport cholesterol into different tissues, different cells of the body for storage, deposition, everywhere. So familial hypercholesterolemia is a disorder where low density lipoprotein is high. Not exactly cholesterol, not total cholesterol. So don't be confused, maybe thinking because it is hypercholesterolemia and start to think of cholesterol. It is always low density lipoproteins. Familial hypercholesterolemia. Okay? Yes, that is it. It is high, low density lipoprotein. Now, we have also premature atherosclerosis. This is LDL.
It is also LDL.
Yes, then transportation of 70% of plasma cholesterol. It is also LDL, isn't it? Yeah, those questions are not also called the MLS only questions, but not really. Not doesn't mean that like actually all of them difficult. Even some of them are very simple. Of course, after reading, because when you didn't read, you can't can say this question is simple. After reading, you know that almost every plasma cholesterol is transported by low density lipoprotein, isn't it? Low density lipoprotein, the one that transport cholesterol. Chylomicrons does not transport cholesterol, but it transports triglyceride from food, dietary.
Yeah.
Dietary.
Stomach.
Yes. Very low density transport what? VLDL. What does it transport? What does it transport? Very low density, if you remember. You don't remember? What does this transport? Remember. And you're going to remember also high density. Okay, high density is okay. But at least very low density. What does it transport? Do you remember what is called endogenous lipids? Endogenous. The lipids that is produced by the liver itself, that's what you call endogenous lipids. It is packed into a very low density lipoprotein and be transported so to the peripheral tissues. But there, as it is going to be broken down, it is going to be destroyed, and it will be converted to the intermediate and then to low density lipoprotein. So that is how VDLL is converted. VLDL is converted into LDL.
So it transports mostly triglycerides.
The VLDL.
Okay. The ApoB is not so. The Apo.
Well, ApoB is for all of them. It depends on which ApoB, because we have ApoB 100 and ApoB 48. Depends on for most of these actually ApoB 48 are found here. Low density, very low density. So it's not an issue of which apolipoprotein that is contained, but where is it formed and what it does transport. This VLDL is manufactured.
It's formed in the liver.
Produced in liver.
Yes.
And it is packed quickly with the cholesterol in the liver. That's what you call endogenous cholesterol. Okay. Yeah, so for more information, we have it there. So you can open lipids and lipoproteins, and it will be very helpful. Finally, we have question number 43, where we talk about this is also a question that is usually appear in exam. This one I have seen it even. I don't, maybe my own exam. Maybe it has been a long time ago. It's a long time ago, but I think I saw it where they ask familial absence of high density lipoprotein disorder. What that disease? How do we call it? Familial absence of high density lipoprotein. It's called Tengia disease. Yes, Tengia disease is the one that is characterized by what you call, it is called what? Hypobeta lipoproteinemia. Yes. Hypobeta lipoprotein, not beta. I mean, I think it is going to be alpha. Yes, hypoalpha lipoproteinemia, because it is because of ApoA content lipoprotein, which is HDL. So it is called Tengia disease. You will also see there especially when someone has maybe less than 3 milligrams per deciliter of HDL in the blood. Those people, they are suffering Tengia disease. Okay. So I think we would have more to talk about even these ones, but I think we'll have another session yes, we're trying to have other sessions in coming days with time. Okay, sometimes trying to discover something about these questions. So maybe we can plan again, even if we have it on weekdays, even if we have it on Fridays or sometimes Saturdays. I will try my best. Yeah, sometimes, yes, sometimes at least every week to have one session like this. I think that can be helpful. So not only in chemistry, but also in other subjects, especially whenever we have time and we meet like this. Okay, so thank you so much. I really appreciate participation, and even attendance was good. So we are going to upload this on the website. I think it is well recorded. It will be there in case someone wants to revisit and trying to remember what we said. That will be on our website. So we'll have to hold this session again, maybe next week. We will plan and communicate. Thank you so much. Thank you. I appreciate.
Thank you, sir. It's been a very good session.
Thank you. See you.